So we were discussing benign esophageal stricture. When you will suspect benign esophageal stricture, if someone with a history of bisphosphonate intake such as alendronate or NSAID intake present to you with dysphagia for both solids and liquids without regurgitation, then you will suspect. Without regurgitation and weight loss, then you will suspect benign esophageal stricture. So the important point in history would include history of intake of bisphosphonates such as alendronate, or history of intake of NSAIDs such as for rheumatoid arthritis, or a history of GERD present to you with dysphagia for both solids and liquids without any regurgitation or weight loss, then it is benign esophageal stricture. Now, can someone please read the scenario at the bottom of the picture? Yes, Dr. Shafqaz, please.
Yeah. 23-year-old female with lethargy, weight loss, abdominal discomfort, bloody diarrhea more than 8 times a day. Endoscopy reveals deep ulcers and skip lesions.
What is your diagnosis?
There is skip lesions and weight loss as well. I will go for ulcerative colitis. Sorry, Crohn's disease, because the skip lesions can then cause cobblestone appearance, I think.
Yes, you're right. Excellent. Skip lesions and deep ulcers on endoscopy are typical finding of Crohn's disease. Though in the scenario, the diarrhea is bloody, and bloody diarrhea is commonly a feature of ulcerative colitis. But here, the endoscopy findings such as deep ulcers and skip lesions are more in favor of Crohn's disease. So it's Crohn's disease, yes. Can anyone tell me the endoscopic findings of ulcerative colitis? What will we see in on colonoscopy in ulcerative colitis?
Sled pipe, drain pipe.
Any other? What kind of ulcers you will see in ulcerative colitis?
I think there'll be granulomas.
That's histological findings of Crohn's disease, not of ulcerative colitis. In Crohn's disease, there is granuloma formation and increased goblet cells. Colonoscopy is basically a camera. So what will we see in the colon if we put a camera inside? We will see loss of ostration.
Oh, yes.
And superficial ulcers on colonoscopy in ulcerative colitis. Yes, superficial ulcers. While the findings that you are telling that granuloma formation and increased goblet cells, they are histologic findings of Crohn's
Crohn's
disease.
disease. Sorry.
Yes, their histology. Our next topic is acute pancreatitis. Remember that acute cholecystitis, ascending cholangitis, and acute pancreatitis, uh, they all can be confused. So in acute cholecystitis and in acute ascending cholangitis, there is usually right upper quadrant pain with fever. In case of ascending cholangitis, there will be jaundice. And in case of acute cholecystitis, there will be nausea, vomiting, and positive Murphy sign. While in case of acute pancreatitis, first of all, you need to remember the risk factors for pancreatitis. Gallstones, the most common risk factor for 80% of acute pancreatitis cases are caused by gallstones. Gallstones which are dislodged and that obstruct the common bile duct can lead to acute pancreatitis. So more precisely, stones in the common bile duct, which is also known as choledocholithiasis. Stone in the gallbladder is cholelithiasis, while stone in the common bile duct is choledocholithiasis. So the most common cause of acute pancreatitis is gallstones. The second one is alcoholism. Third one is trauma, and fourth one is ERCP. There is a mnemonic to remember the risk factors for acute pancreatitis. Get smashed. Get G for gallstones, E for ethanol and ERCP, T for trauma. So you need to remember these four causes only. Other causes are rare and not that important for Plab exam, which you can remember from this mnemonic. So how a patient with a history of gallstones present to you with epigastric or upper abdominal pain that is radiating towards the back and that is relieved by sitting or leaning forward. Relieved by sitting or leaning forward in a patient with a history of gallstones, you will think of acute pancreatitis. A person with a history of gallstones present to you with right upper quadrant pain, fever, and jaundice, then you will think of ascending cholangitis. A person with a history of gallstones present to you with upper abdominal pain that is radiating towards the back and relieved by sitting or leaning forward, then you will think of acute pancreatitis. There will be nausea and vomiting as well. And pancreatitis can lead to tachycardia, shock, and periumbilical bruising, which is also known as Coulin's sign. What are the investigation for the diagnosis of acute pancreatitis? Initial investigation includes serum amylase and lipase. Remember that lipase is more specific and sensitive for acute pancreatitis. Serum lipase will be more than 3 times the upper normal limit. Initial investigation for the diagnosis of acute pancreatitis is serum amylase and lipase. Lipase is more specific and sensitive. It will be 3 times the upper normal limit. To confirm our diagnosis, we'll perform CT abdomen with contrast. A CT scan with contrast of the pancreas will be performed for the confirmation of the diagnosis. The treatment, initial treatment for pancreas is same as of acute cholecystitis. and ascending cholangitis, which is fluids, analgesics, and antibiotics. Broad spectrum antibiotics such as imipenem in severe or moderate cases. And if there is evidence of necrosis on CT scan, decontaminant is also needed. Surgical, as pancreas is a retroperitoneal structure, is lying close to the posterior abdominal wall. It lies behind the stomach and behind the lesser sac. So the surgical debridement is done through transgastric endoscopy and assisted translumbar retroperitoneal necrostomy. In short words, transgastric surgical debridement is done through an endoscopy. So initial management is fluids, analgesics, IV antibiotics in moderate to severe cases, and if there's evidence of necrosis on CT scan, then surgical debridement. Next one is ascending cholangitis. Charcot triad of fever, right upper quadrant pain, and jaundice will make the diagnosis of ascending cholangitis. Along with this triad, if there is hypotension and behavioral changes, then it is known as Charcot pentad. Treatment is same: fluid resuscitation, antibiotics. The definitive treatment, if as the cause of ascending cholangitis is stone in the common bile duct, which leads to ascending cholangitis, means infection of the common bile duct due to common bile duct stones, which will result in fever, right upper quadrant pain, and jaundice. The triad of these three symptoms is called Charcot triad. Treatment is same in case of acute pancreatitis. The initial treatment is same as ascending cholangitis and in acute cholecystitis as well. While the definitive treatment is different in all the cases, the definitive treatment in case of ascending cholangitis is early ERC. Is it clear to everyone up till this point? Or anyone want to ask any question?
Yeah, I want to ask a question about this acute cholangitis. The difference between acute cholangitis and ascending cholangitis is acute one is Charcot triad and ascending is along with it hypertension and leukocytosis.
No, acute cholangitis and ascending cholangitis are barely the same.
So what
you
is?
can use both the names interchangeably.
But the pentad, what is that?
Yes, the Charcot pentad, if a patient with ascending cholangitis develop hypotension and confusion or behavioral changes, then it is Charcot pentad. Fever, right upper quadrant pain, jaundice, hypotension, and behavioral changes or confusion.
Is there another name for it? Something like Raynaud or something like that? Sure.
Yes, you are right.
Mm-hmm. Yeah, I think it's
I don't remember
name.
the exact name. Renaud pentad, I think.
Yes, that's the one. Yeah, just wanted to clarify. Thank you.
Questions? No questions? Okay, or Dr. Sali, you can unmute yourself and you can speak in the mic. Yes, it's Renaud Pentard. The questions are the questions that you ask in the chat are not being recorded in the lectures. I basically want your questions to be part of these recorded lectures, so they can be helpful in the future for mm, the future students. That's why it will be better if you can ask or speak in mic. Now, some notes on organisms causing diarrhea. We discuss the causes of diarrhea. Can someone revise the causes of
Sorry,
diarrhea?
can I just ask one question? Is there
Yes,
another
yes.
peptic structure? So what are the signs and symptoms of that? Is there anything like peptic structure as well? Like
Yes,
there is an esophageal structure. So is there a peptic structure as well?
peptic seizure will be most probably in the stomach.
Mm-hmm.
So peptic stricture, other than causing epigastric burning, if there is ulcer, but if an ulcer is healed in the stomach and it is not due to gastric carcinoma, then it will not have any sign or symptom.
Okay.
The stricture in the esophagus lead to narrowing of the esophagus. That's why it will result in the dysphagia, etc. But as a stomach is a very vast tube-like structure, so a stricture in the stomach will not cause any problem.
Okay. Yeah. Thank you.
So now we'll discuss some organisms which causes diarrhea. Before we discuss the causes of acute diarrhea, can any one of you revise the causes of chronic diarrhea that we have discussed so far?
Inflammatory bowel disease.
Yes, Crohn's disease and ulcerative colitis.
Yes.
Any other cause of chronic diarrhea?
Villus adenoma.
Yes. Any other cause?
Celiac disease. Celiac disease.
Yes, celiac disease. Now some notes on infectious diarrhea or acute diarrhea. A traveler diarrhea is someone with a history of travel to Africa that is of short period and self-limiting. The duration of the diarrhea is usually 2 to 3 days. Then it is organism is E. coli. Someone with a history of travel and diarrhea more than 10 days, or if there's a history of weight loss, then this diarrhea is most probably due to giardiasis or giardia lambda. So traveler diarrhea of short duration, E. coli. Traveler diarrhea of longer duration, more than 10 days, then it is giardiasis. Now a traveler diarrhea in which there is a history of prodrome, high fever, headache, myalgia, which is followed by bloody diarrhea, then the diagnosis will be, or the causative organism will be Campylobacter jejuni. Diarrhea in pediatrics, the most common cause of diarrhea in pediatrics is rotavirus. Diarrhea that is associated with weakness and areflexia is Guan syndrome. Diarrhea with renal impairment plus hemolysis, hemolytic uremic syndrome. Diarrhea that is followed by right upper quadrant pain is amoebic dysentery. Diarrhea after eating egg or chicken is salmonella. Diarrhea after antibiotic is pseudomembrane colitis. And the last, diarrhea in a bedridden patient or handicapped patient with stony hard stool is diarrhea, which is also known as spurious diarrhea or diarrhea due to fecal impaction. So diarrhea bedridden patients develop stools and impaired stool. Some of the fluid can seep through stool or from the sides of the impacted stool. So impacted stool can also cause diarrhea. Now, can someone please read the scenario in the at the bottom of the page?
So this scenario is not like visible.
Let me zoom it a little bit.
Yes.
Is it visible now?
Yes, sir. Can you please move a little up? This line is half visible, the second one.
Now?
Yes, now it's okay. Should I read it now?
Yes.
A mass has been removed from the cecum. Right side, the histopathology report shows transmural infiltration with the lymphocytes and granulomas without necrosis.
What's your diagnosis?
It's
Anyone can answer this.
It's a
non-cancerous.
Crohn's disease
Crohn's disease.
because of the transmural infiltration.
And also non-caseating granuloma.
Yes. A mass. What is the most common site that is affected by the Crohn's disease? Or from where, which site, from which location the Crohn's disease usually start?
It's the right side.
Ileocecal
Yes, it's the
junction.
right ileocecal junction. So a mass has been removed from the cecum. What is that mass? That mass is basically granulomas. Granulomas, transmural infiltration. The diagnosis of Crohn's disease is made. Crohn's disease starts at the ileocecal junction in the right iliac fossa. On histology of Crohn's disease, there is granuloma and increased goblet cells. Endoscopy will show skip lesions, deep ulcers, and cobblestone appearance. Small bowel enema will show Cantor string sign and rose thorn ulcers and fistulas. Now let's see who answered this one. A 55-year-old woman, severe abdominal pain that radiates towards the back for 1 day, plus nausea and vomiting and tachycardia, and looks in shock. No fever or diarrhea, history of gallstones. What is the diagnosis?
Acute cholecystitis.
Acute cholecystitis. Anyone else want to answer this one?
Acute pancreatitis.
Anyone else want to answer this one? One answer is acute cholecystitis and one is acute pancreatitis. So severe abdominal pain that radiates to the back. Nausea and vomiting and tachycardia. Where will be the pain in the case of acute cholecystitis?
Right
So the pain
hypochondrium.
will be right
upper quadrant.
upper quadrant.
Right upper quadrant or right hypochondrium. Plus there will be nausea and vomiting, that's right. Plus the pain of cholecystitis can radiate towards the back.
Does it not go to the tip of the shoulder? The
Yes,
acute
case of
cholecystitis
acute
pain.
cholecystitis will radiate towards the tip of the shoulder. So it most likely look like a case of acute pancreatitis, because the most common risk factor for pancreatitis is gallstones. Let's see. Yes. Initial investigation in this case will be serum amylase and lipase. So we pick acute pancreatitis because the pain is abdominal pain. They are not mentioning the location that if it's right hypochondrium or right upper quadrant pain. Now, what's the diagnosis in the key number 22? Young age diarrhea, sometimes bloody, chronic abdominal pain, and tenesmus.
Celiac
Can anyone
disease.
tell the diagnosis? Celiac disease.
No, bloody
Young
diarrhea is
age
mostly
diarrhea.
ulcerative colitis or Crohn's disease.
So yes,
bloody
it's more
diarrhea
common in
will be
ulcerative
inflammatory
colitis. So one hint is towards the, in these kind of scenario, you need to look at the hints. So this is one point that is favoring ulcerative colitis, plus young age, plus chronic abdominal pain, plus the last one is tenesmus. What is tenesmus? Tenesmus is basically a constant urge of defecation, and it is mostly present in proctitis. Proctitis is basically inflammation of the rectum. As we discussed in the previous scenario, that the most common site that is affected by the Crohn's disease is ileocecal junction, or the, though it can affect the entire enteric tract, but it usually starts from ileocecal junction. While in case of ulcerative colitis, the disease usually affects rectum, sigmoid colon, and descending colon, and it usually does not extend beyond the descending colon. So it most likely looks like a case of ulcerative colitis. Inflammatory bowel disease, ulcerative colitis, or Crohn's disease. Irritable bowel syndrome can also have diarrhea, but in irritable bowel syndrome, the diarrhea is usually watery diarrhea and not bloody diarrhea. Diverticulosis usually occurs in old age and they are asymptomatic unless complicated.